See.
Yeah. So, good evening, everyone. And today seems to be the planned last episode of this webisode of Decoding GI and HPB Oncology. And it's been now more than 1.5 years that we have been running this academic program for basically GI and HPB Oncology. For the students, it's purely academic session, as you all know. And we have so far covered majorly every organ in GI and hepatobiliary oncology, covering its starting from the basic anatomy, pathology, physiology, radiology, until the metastatic disease. So we have reached the last session for colon cancer, which is management and approach towards non-colorectal liver metastasis, oligo or metastatic disease. The unresectable metastatic disease we have discussed in the last session, and today we will be more focusing on the resectable part of that oligometastatic disease. And we have eminent faculty again with us. So for lecture, we have Dr. Durgatosh Pandey, who is a senior surgical oncologist from Tata Memorial Center, Varanasi. And we have Dr. Asit, Arora, who will moderate the panel discussion. The format will be same like a lecture followed by the panel. And the panelists would include Sir himself, and Dr. Vinay Kumar, who is a surgical oncologist from AIIMS Bhopal, Dr. Abhishek Mitra from Paras Hospital, Gurugram, Dr. Sapna Marcus, who is a radiation oncologist from AIIMS Bhatinda, and Dr. Garg, who is medical oncologist from Sanar International Hospitals. So I welcome you all, and Sir, please take over the stage for your lecture. I welcome you again.
Okay, good evening, all of you. Is it my turn? Should I start?
Yes, sir, absolutely. Definitely.
Okay. All right. 1 second. कैसे होगा?
इसको full slide कर लीजिएगा. Yeah, yes, sir. It's visible now.
Got it. Yeah.
Is that now? Okay, right.
Yeah.
So, so I have to speak on oligometastatic colorectal cancer, and it seems the liver thing has already been discussed. So I will discuss the things which are other than non-liver. Okay. So I can't change it. 1 second. Okay. So oligometastatic colorectal cancer, what is the definition? It is generally defined as up to 5 lesions, up to 3 metastatic sites. So 5 lesions and 3 systems, beyond which it is no longer oligometastatic. That's an arbitrary cutoff. So there is some variation in the opinion among the surgeons, but generally it is considered at up to 5 lesions in no more than 3 metastatic sites. Now, synchronous and metachronous, again, it's an arbitrary cutoff. 6 months is a cutoff. Within 6 months of the diagnosis is synchronous, and after 6 months of the diagnosis, it is told as metachronous. Now, we know that 20% of all colorectal cancer will present with metastatic disease, and 35% will develop metastatic disease after upfront treatment for localized disease. Now, while 35% of the patients, of such patients present with oligometastatic disease, less than 10% of the metastatic colorectal cancer would be actually operable, resectable. Generally, this is the flow of treatment. We have broadly 3 ways to treat such oligometastatic disease. One is surgery, the other one is systemic chemotherapy, some anti-cancer treatment. It also includes some radiotherapy. It may be ablative treatments. These are the 3 broad headings under which we discuss the treatments. Surgery would be resection of whatever metastasis we have. In liver, it is liver metastastectomy, it is lung, it is pulmonary metastectomy, etc. Systemic anti-cancer treatment can be with chemotherapy, it can be neoadjuvant, it can be adjuvant, it can be targeted therapy, it can be immunotherapy, anything. Ablative therapy can be localized when it is stereotactic body radiation or brachytherapy. It may be radiofrequency ablation, microwave, or cryoablation. Loco-regional treatments are like some kind of a tear, radioembolization, or TACE, or it can be a local chemotherapy as well. Now, what is the proof of concept? Previously, the colorectal cancer with distant metastasis long time back was considered to be an unresectable thing. But people started resecting the liver metastasis, and they found that the survival rates are actually up to 42%. I mean, it varies from 20% to 45%, but this kind of a survival was seen with surgery alone for solitary lesion. So this was a proof of concept for the oligometastatic theory, and this has been brought again to other areas as well. So the management decision has to be whether the patients have currently unresectable disease, it is a potentially resectable disease, or is a never resectable disease. So these are the three broad headings in which when we see the patient in the clinic, we make up our mind that, okay, this is currently resectable but metastatic. This one is potentially resectable, and the other one would never come for surgery. And based on that, we make our decisions. We come to lung metastasis. The first resection of pulmonary colorectal mets was reported by Blalock in 1944. And then subsequently, the multiple series have demonstrated that survival benefit is there with pulmonary metastectomy with a current aggregate survival of about 35% in 5-year survival. Now, how do you stage it? A multi-detector CT scan should be all right, but nowadays everybody would do a PET CT because other than the lung, we are also concerned with extrathoracic disease as well. Does he have a liver metastasis also? Does he have a liver metastasis to brain, to bone, to other sites as well? To unsuspected lesions in the hilar lymph node or mediastinal lymph nodes along with the lung metastasis, because all of these will have some implications on the outcome of the patient. Now, how do we select such patients? The colorectal primary should be controlled, or if it is a synchronous lesion, it should be a controllable disease, which means the colorectal primary should be considered resectable. There should be an absence of extrathoracic disease, or if an extrathoracic disease is present, for example, there is a liver metastasis as well, it should be either resectable or ablatable. The pulmonary metastasis should be completely resectable, and R0 resection is the goal, and the patient should have an adequate cardiopulmonary reserve to tolerate this kind of a surgery. Now, how do we approach? The operative approach for pulmonary metastectomy in these situations depends on several factors. One is the number of pulmonary metastases, the size of the lesions, the location, and the lobe involved. So we have two different approaches. We have VATS, we have thoracotomy. And within thoracotomy, I also include the clamshell incision. I also include the median sternotomy, etc. So if we have up to 3 lesions, they are less than 1.5 centimeters in size, each of them. The location is peripheral, and predominantly the involvement is in upper or middle lobes. Then VATS is a decent approach for a pulmonary metastectomy. In contrast, if there are more than 3 lesions, the size is more than 4 centimeters. Now, between 1.5 and 4 centimeters, there is a gray area. You can make decisions based on several factors. But if it is more than 4 centimeters, it's a centrally located thing, or a lower lobe is involved, then VATS is not a good approach for such lesions. We need an open thoracotomy approach for such situations. Now, extent of resection. We know that the metastases are more commonly located peripherally in the lung parenchyma and is more frequent in the lower lobes. In the International Registry of Lung Metastasis, the most common pulmonary metastectomy performed was a non-anatomical wedge resection, which is by far the most common metastectomy procedure, which is done for a variety of cancers, primary, whether it is sarcoma or colorectal lung metastasis or whatever. Up to 70% of such resections are non-anatomical wedge resection. Lobar resection in 21%, segmentectomies in 9%, and pneumonectomy very occasionally in 3%. So a pneumonectomy is rarely performed as the initial procedure for metastectomy because the post-operative mortality rate is quite high, up to 5%, and lack of conservation of lung parenchyma. Despite all that, the survival rate is only 16%. Now, the patients whose disease pattern includes both hepatic and pulmonary metastasis have been shown to have a good outcome with either sequential or simultaneous liver and lung resections. Up to 50% of 5-year survival rates have been shown in these patients. So what is the outcome? There was a good meta-analysis from the Heidelberg group of 14 studies, about 1,684 patients. Perioperative mortality ranged from 0 to 2.5%. Majority had wedge resections, unilateral procedures. Overall survival in these situations was 48% for 5 years, in 5 years. Now, within this 48%, if we see the patients in whom there was an absence of lymph nodal disease, the survival rose to 60%. And in the presence of peribronchial and hilar nodes, the survival was reduced to 17%. And no patient with mediastinal lymphadenopathy with lung metastasis survived for 5 years. So here comes the reason why we need to do certain investigations in order to, for example, PET-CT. It is a good investigation to pick up the hilar lymph nodes or the mediastinal lymph nodes along with the pulmonary metastasis. Now, repeat pulmonary metastectomy. You have already done a pulmonary metastectomy. The patient presents with a repeat lung metastasis. There is conflicting data to support the resurgery. Majority of the people will not operate, but some people would operate, and Kim and colleagues show that 5-year survival is not different between the patients undergoing primary pulmonary resections or second pulmonary resections as well. So this is the flow which goes. First question we ask whether it is an isolated thoracic disease, whether it is a resectable disease, whether the patient is fit for surgery. If the answer to all these questions is yes, then you go down and see if it is a unilateral disease or a bilateral disease. If it's a bilateral disease, it's a staged procedure generally, either a staged VATS or a staged thoracotomy. If we want to do as a single procedure, then the options are either median sternotomy or a clamshell incision. Clamshell incision is an anterior thoracotomy on both sides and cutting the sternum across horizontally. Now, if the answer to these questions, isolated thoracic disease, if it is a unilateral disease, then the next question to be asked is, are there less than 3 lesions? Are the lesions less than 1.5 centimeter in size? Are they peripheral? Which lobes do they involve, upper or middle? If the answer is yes, the approach is VATS. If the answer is no, the approach is thoracotomy or any other open approach. Now, you go back to the first question which we asked, first 3 questions: isolated thoracic disease, resectable disease, patient fit for surgery. Either of these things, answer is no. Then the options are non-resectional treatment. And what are the non-resectional treatment? We have discussed. It's radiofrequency ablation. It can be a chemoradiation. It can be palliation. Now, after lung, we come to next common site, which is now an exciting field, which is a peritoneum. So in retrospective studies of colorectal cancer patients, up to 13% patients will present with peritoneum as the only site of metastatic disease, and up to 4 to 5% of patients. Now, historically, the peritoneal carcinomatosis from colorectal cancer have been shown to have a poor prognosis with a median survival of 6 to 8 months. But then came the procedure of cytoreductive surgery and coupled with HIPEC. And it was shown that the survival was up to 3 and 5 year survival was 41% and 27% respectively. And the median survival was 30.1 months. This was a retrospective analysis. Then there was a randomized trial which was published in 2003 by Agrawal et al. And this was about cytoreductive surgery with HIPEC. And it showed a median disease-free survival of disease-specific survival of 22.2 months in the CRS HIPEC arm versus 12.6 months in the standard arm, which means it was non-surgical arm, whether it was a palliative surgery followed by chemotherapy or whatever, but it was not a standard cytoreductive surgery and HIPEC. So this was the difference in the median disease-specific survival, 22.2 months versus 12.6 months. So it appears that in patients with peritoneal metastasis from colorectal cancer, cytoreductive surgery and intraperitoneal chemotherapy may improve the outcomes. So what are the absolute exclusion criteria of such surgery? Bulky and diffuse peritoneal metastasis. People now say that we now assess the bulk of peritoneal metastasis by peritoneal carcinomatosis index, PCI. And very few people will now do this surgery for PCI, which is more than 25 or 26. Then unresectable extra-abdominal metastasis, very small, vast small bowel serosa or small bowel mesentery involvement. You see, when the mesentery gets involved, it becomes very short. It is very difficult to get rid of all the disease in the mesentery if the mesenteric involvement is extensive. The parietal peritoneum, it's easy, but mesentery is the Achilles heel in such surgeries. So an extensive mesenteric involvement becomes exclusion criteria. Multi-segment malignant bowel obstruction, and if we have very less amount of small bowel left after the surgery, large resection of small bowel, we don't want to land up in a short bowel syndrome. So that becomes another exclusion criteria. Massive affection of hepatic hilum. In the pota, the disease, if the disease in the pota is too much and it cannot be safely resected, this also becomes an exclusion criteria. The presence of unresectable liver metastasis or the requirement of major hepatectomy could lead to insufficient hepatic function in such situations. Although liver metastectomy is also commonly done concurrently with peritoneal metastasis, the cytoreductive surgery and HIPEC. However, very few people will do when the number of liver lesions become more than 4 or 5. In such situations, along with the cytoreductive surgery and HIPEC, this procedure is probably not worth. Now, what determines the morbidity and mortality after such a procedure? So there are patient characteristics, the age is there, the performance status, hypoalbuminemia. Operative factors, very importantly, are pancreatic resections. So sometimes we need to do such resections because omental disease may extend to splenic hilum, and when you do a distal pancreatectomy and splenectomy may be an surgery which can be associated, added to cytoreductive surgery with HIPEC. Bowel resection anastomosis is often done. The surgeon experience is one factor, and the PCI. So the greater the PCI, the greater the morbidity. The next question is, do we really need HIPEC after colorectal cancer, after cytoreductive surgery in a colorectal cancer peritoneal metastasis? Now, in a standard way, most of us were doing cytoreductive surgery and combining it with HIPEC. We still do in majority of the situations. But there was a phase 3 randomized trial which was published last year in Lancet Oncology, Prodige 7 trial, which was done across several institutions in France. And they took patients with PCI less than 25. There were 265 patients, 133 in one arm and 132 in another. The median follow-up was more than 5 years, 63.8 months. And they showed that there was absolutely no difference in median overall survival or recurrence-free survival. Overall survival was 41.7 months in CRS HIPEC versus 41.2 months in only CRS arm. And recurrence-free survival was 13.1 versus 11.1 months. So this raises an important question, whether we are over-treating such patients in colorectal cancer with a HIPEC, whether cytoreductive surgery alone is sufficient for colorectal cancer. Now, there are several limitations of this study. There are several criticisms, but this is the best randomized trial we have got so far, which says that in colorectal cancer, probably we can do away with HIPEC and perform only cytoreductive surgery in patients who have got PCI of less than 25. Now we come to brain. So in brain, the most commonly reported symptoms were epileptic seizures, raised intracranial pressure, or neurological symptoms. Now, in a study that screened all patients of metastatic colorectal cancer, regardless whether the symptoms were present or not, with an MRI of the brain, they found that 76% of the patients with brain metastasis were asymptomatic. So the overall incidence of brain metastasis in colorectal cancer is 2.1%. And PET-CT was superior for identifying lymph node metastasis. The loco-regional thing and the other things, the PET-CT was superior. However, the MRI was superior to delineate the lesions within the brain, especially for the lesions which were less than 1 centimeter. Now, there is a correlation. These were the studies which demonstrated a correlation between lung metastasis and brain metastasis, which is to say that the patients who present with lung metastasis, they have a higher likelihood of having a brain metastasis. In contrast, liver metastasis does not have a correlation with a brain metastasis, but a colorectal primary with a lung metastasis has got a higher chance of developing brain metastasis. So if we are evaluating a patient of lung metastasis for a possible resection, it makes sense to add a contrast MRI of the brain in such situations. So the best treatment, it is said that it is a surgical resection with radiotherapy. So best survival rates were reported in patients who were treated with neurosurgery, with radiation or chemotherapy. So this was the difference. The overall survival was dismal. It was a median survival was achieved for about 17-18 months in a patient who had surgery with radiation and chemotherapy versus less than 10 months in patients who have had no surgery, only radiation and chemotherapy. So again, the flow will go. The first question to be asked is, does the patient have any neurological symptom? If it is yes, then obviously we have to add MRI to the MRI of the brain to the in all the evaluation. If the answer to this question is no, then the next question we ask, does the patient have risk factors? If there are no risk factors, no further diagnostic procedure is required, and we do not investigate the brain in such situations. If the patient has risk factors, we do a contrast MRI again. And what are those risk factors? The risk factors are lung metastasis, RAS mutation, high CEA level. There is no cutoff to this, but generally we will consider as 10 to 12 will be the cutoff of CEA levels, and rectal cancer. In such situations, it is prudent if you are approaching a metastatic colorectal cancer to exclude brain as a potential site of metastasis. If you do the MRI and the diagnosis from MRI is still uncertain, then a spinal fluid examination may be added to this procedure. The therapeutic algorithm, we'll see what is the performance status of the patient. If the performance status is good enough for therapy or not. If not, then the patient goes for best supportive care. If it is good enough for therapy, the next question we ask is resection and reasonable for oncological concept? If yes, is the neurosurgery possible? Yes, do the surgery. It's not possible, stereotactic radiosurgery or gamma knife radiosurgery possible. If yes, then we do SRS or gamma knife. If not, then whole brain radiation. And following radiation, we consider additional radiation. Following surgery, we consider radiation as well. This is obviously will be combined with systemic therapy also. We come to bone. The bone metastasis is seen in up to 6% of patients. Yes. Is there a question?
No, there was some disturbance. I've muted.
All right. So the incidence of bone metastasis in colorectal cancer is up to 6%, and in autopsy cases, it's much higher. Now, in cases in whom the bone lesion is operated, right? So in those patients, if there is a solitary lesion, then the survival is better, and the multiple bone metastasis, the survival is less. This will also hold true if the bone metastasis is associated with visceral metastasis. So patient has a liver metastasis and a solitary bone metastasis. If the survival is X, median survival, it will be much, much less than X if the patient has the same visceral metastasis with multiple bone metastasis. The factors which are potentially associated with patient survival, again, solitary metastasis has an important role to play here. Multiple metastasis, very few patients do well. So bone metastasis should be suspected in patients with colorectal cancer who present with signs and symptoms of an impending or complete pathological fracture, such as pain, inability to bear weight, or signs of spinal compression. If present, if it is associated with a poor prognosis. Patients with metastatic lesions needing surgical treatment, the median survival is very less. It's about 6 months. And few patients survive 1 year. This indicates a worse prognosis for patients in this group compared to those patients who do not require surgical intervention. Now, it may seem counterintuitive But why does a patient of bone metastasis require a surgical intervention? It requires a surgical intervention only when the bone metastasis has become symptomatic enough for either the patient to be non-ambulatory or to have a spinal compression. So the disease is more extensive. So the patients who require bone surgery for bone metastasis have a very poor survival. So now I think this is the last one. The synchronous para-aortic lymph node metastasis, maybe metachronous also. So these are not very common things, but not very rare also after the advent of PET-CT. So incidence of isolated metastatic para-aortic lymph node is 1 to 2%. It will be associated with other diseases, but the isolated metastatic para-aortic node will be less. In stage 4 patients, R0 resection, if possible, is usually recommended for resectable patients in lung metastasis. But for metastatic para-aortic lymph node, it is very controversial. No two surgeons have uniform view as to whether the metastatic para-aortic lymph node should be addressed surgically or not, and whether it should be addressed synchronously or metachronously. So overall survival and recurrence-free survival for patients with R0 para-aortic lymph node dissection, it is up to 39%. So there is a good data to suggest that if it is an isolated para-aortic lymph node, then one should do surgery. Recurrence-free survival is 25% and overall survival was 39%. However, it has not turned into the practice, but it shows a good data to justify the approach with a retroperitoneal lymph node dissection in such situations. Now, recurrence pattern after para-aortic lymph node dissection is generally distant. Those patients who recur, most of them will recur, and 94% will have a distant recurrence, and up to 6% of the patients will have either a local recurrence in the colorectal sites or a loco-regional recurrence in the para-aortic bed. So in such situations, R0 synchronous para-aortic lymph node dissection in colorectal cancers have had good oncological outcomes. The prognostic factors would be pathological T-stage, time to recurrence, and recurrence resections. I think that's it from me. Thank you very much. And I'm open to questions or whatever.
Yeah, thank you so much, sir, for this nice presentation and summarize things. So there are a couple of questions in the chat box. So there is one question: what is the minimum margin we take for metastasectomy? Is negative margin sufficient, or should we take a circumferential margin of any length? So the site is not specified, but I think
Yes.
the question is asked for a general one.
Yeah, I understand. So this question has not been in lung and other areas. It has been well answered in liver. And we extrapolate the same information from the liver. In liver, the aim is to take a margin of around 0.5 centimeter or 1 centimeter. There are different surgeons who will have different opinions about it. But more or less, a negative margin should be sufficient. So we do not go for a wide margin in liver. You can have a wide margin in the peripheral area of the liver. You cannot have a wide margin near the hilum. You cannot have a wide margin near the middle hepatic vein. So in such, similarly in lung, in a peripheral region of the lung, it's easy. Cut a stapler across, you get 2 centimeters of margin. What do you do with the patients who have central lesions? The margin is not enough. So we go to as much parenchyma preserving surgery as possible is the goal for both lung as well as liver metastasectomy. In peritoneal metastasectomy, it's impossible to achieve big margins. So the idea is to just clear off disease and achieve what we call it as CC0. CC0 is you have cleared all the disease. That should be our goal. The margin, I don't think is a negative margin should be enough. That's my opinion.
Yeah, I think this similar question was there in the chat box. So what would be our margin after chemotherapy? Say suppose we start with the conversion, and does it differ as per without chemo or with chemo? So I think you have answered it well.
Whether it is a upfront surgery or it is a surgery after chemotherapy, for the margin in a metastatic disease. Yes, I'm coming to that. Whether we are operating upfront without chemotherapy or we are operating after chemotherapy. Majority of the times we will be operating after chemotherapy, especially in lung metastasis, etc. In any of these situations, the margin should not matter if it is negative. There was a study in liver metastasis which said that margin of 1 centimeter does better than margin of 2 millimeters. That's accepted. But if there are multiple lesions, you cannot achieve a 1 centimeter margin all around in all the lesions. So what is acceptable now is, if you can get a margin of 1 centimeter, 0.5 centimeter, well and good, very good, go ahead and get it. But if we cannot, there are multiple lesions, there are limitations to such wide excisions, then a negative margin should be good enough for metastectomy.
Right. And the next question is, what is PIPAC? Okay, pressurized intraperitoneal chemotherapy. So would you like to take this question? What is PIPAC, and can PCI be assessed on PET-CT or it's laparoscopy mandatory?
So PIPAC is not a curative procedure. PIPAC is mainly a palliative procedure. If we have multiple peritoneal disease which cannot be resected, that's my take on PIPAC. There are people who will differ from me, which is fine. So if the patient has a peritoneal disease which cannot be encompassed with a good CRS and HIPEC, CRS or CRS plus minus HIPEC, then to prevent future obstructions, or to minimize the ascites production, or to prevent an ascites production or minimize it, this is the goal of PIPAC, pressurized intraperitoneal chemotherapy. It is not a curative option.
Right, I agree. And we have done
question
a couple of procedures. Yeah, we have done a couple of procedures of PIPAC in MAX. Basically, it's a palliative intent procedure where the refractory ascites is not controlled by any modality. So we introduce the chemotherapy intraperitoneally with a pressure, and I mean, it works sometimes well to control the refractory ascites. However, PIPAC is being tried as a neoadjuvant modality in various trial sessions or trial-based sessions, but it is still not approved in that setting till now. So the only approved indication currently for PIPAC is to control refractory ascites as a palliative procedure. So next question is, sir, can PCI be assessed on PET-CT or is laparoscopy mandatory? So am I audible to you, sir? Yeah.
Yes, you are. And the second question was something, what was it? PIPAC?
Yeah,
About
PCI.
radiological versus laparoscopic assessment of PCI.
Okay.
Yeah.
So it is very difficult to assess PCI only based on radiological investigations. The peritoneal disease are very hard to be discovered only on the basis of PET-CT or radiological investigations. However, there are indirect measures. What do we see on radiology? We see on radiology whether there is a mesenteric shortening or not. Those things can be sometimes assessed quite decently. You can ruling out a patient of a shortened mesentery from surgical approach can be possible by radiological investigation. However, it cannot give an accurate picture. Having said that, things are changing. There are new techniques of PET-CT. Now my colleagues in I forget what it is called. Some new PET-CT has come in, which is very good in detecting peritoneal disease.
FAPI PET.
FAPI PET. Yes, FAPI PET. We are doing currently a study also in gastric cancer and trying to correlate it with the laparoscopic findings. And FAPI PET is, with the advent of FAPI PET, things may change. But at this moment, I don't think only imaging studies will give us an answer about PCI. In fact,
FAPI is currently undergoing validation. Yes.
In fact, only laparoscopy also is very difficult to give you an accurate estimate of PCI. It's a full laparotomy, and when you have assessed all these structures, you have mobilized the liver, you have gone all around. It is then that you say that yes, this is the PCI. You can estimate the PCI, but accurately the PCI can be measured only after a full laparotomy.
In our experience, it's always like when we do a laparotomy, it's always upstage. The PCI is always higher than what we assessed on laparoscopy.
See, we have to understand this. see, what do people say that you do the diaphragmatic stripping? Where is the diaphragmatic stripping most difficult? On the peripheral area, it's easy. It's easy. As you approach the central tendon of the diaphragm, it becomes more and more difficult. It becomes more and more difficult as you approach the area where the liver joins, the triangular ligament is there. And where is the most dependent portion of the peritoneum? It is there. So in all likelihood, if we have not mobilized the liver, we are likely to leave behind disease there. Because much of the disease, because it is the most dependent site of the peritoneum there, around the liver, it is quite possible that you may leave around disease if you really do not mobilize the liver and see in that area.
Right. And do you agree or disagree that if this is a high-grade morphology in a case of peritoneal metastasis, say suppose signet ring cell or poorly differentiated, so is there any data to support the role of HIPEC? Does morphology rules over the low PCI, or how do you take it?
I am not aware of any study which says that. Having said that, there are two things. See, it is those tumors, the signet ring tumors, which are more prone to have peritoneal metastasis, right? The signet ring tumors will have a greater possibility of having a peritoneal metastasis than, let's say, another non-signet ring variety, non-mucinous non-signet ring variety. So if we rule out CRS and HIPEC from that subset, then we are ruling out it from a vast majority of such patients. Also, the mucinous, it's not mucinous, the signet ring cell carcinoma is a very poor prognostic variant of colorectal cancer in any site actually. If there is a signet ring cancer, it confers a poorer prognosis than a regular adenocarcinoma. So a result of steatoreactive surgery with HIPEC with an equivalent PCI in a signet ring versus non-signet ring histology will be different. That we understand. And that's because of the nature of the disease. But for that, if we can rule out that surgery, I'm not aware of any study that rules out that surgery.
Would PCI differ in making a difference? Say suppose less than 25 you told for other morphologies, or less than 16 say.
So again, there is no data to say that. Yeah. We have the data, less than 25 is, yes. Yes, so less than 25 was the data in Lancet Oncology, that Prodige 7 trial. If you look at some other study, in fact, some people say less than 12. We should not be operating on colorectal cancer peritoneal metastasis, which has a PCI more than 12, because more than 12 has a very poor prognosis. So they have made these three categories: 0 to 5, 5 to 8, 8 to 12, 9 to 12. And then they say that only within this range we should operate. So these are very fluid things. It all depends on institutional protocols. We have to validate our own data and then decide on our own whether we should do such surgeries or not. And to me, 25 is a reasonable option. I have not changed it, whether it is based on the histology. And for colorectal cancer, it's a reasonable option. For, let's say, appendiceal pseudomyxoma, I would consider it for even 35.
Durgatosh, so we generally use a cutoff of around 15.
Yes, that's what I said. That's so 12 to 15 was that from that study, which said that 0 to 5, 5 to 8, and 8 to 12. It was from that study that 15 came. And then comes this Lancet Oncology, in which the Prodige 7 trial is there. And you see good results with it less than 25. So as I said, it is institutional preference, whichever way we can feel. There is no hard data to support that.
Right. And the last question, I think, is put by Dr. Gagandeep. So extensive rectal disease with large liver lesions, moderate peritoneal disease with some mesentery involvement. I think, Dr. Gagandeep, there are certain questions you have not specified in it. So the decision making would depend upon how symptomatic the primary is. Are the liver lesion convertible or potentially resectable, or how good is or how bad is the peritoneal disease? I think please put your question into a straightforward type rather than discussing this whole approach. So we'll be taking such question in the panel discussion also. So Dr. Asit, you can take over for panel discussion and we can continue.
Thank you.
Sir, if you can stop
and
sharing.
you will have to excuse me. I'm still stuck in the hospital and I'll have to go back. So please excuse me.
No worries.
Thank you, sir.
Sure,
Thank
sir.
you for
Yes.
making it.
Thank
Sir, nice talk from you, sir. I'm Dr. Vinay here. You must be knowing. And thank you, Nikhil, for inviting everybody. It was a good talk here from, I can see. And the question I can ask, sir, this metastatic was done right from 1940s. And the concept of oligometastatic lesion came in 1995, I think. So they are very slow growing. This is the group of lesion. They are very slow growing, and that is why the concept of oligometastatic lesion came. So, sir, do you prefer to classify this lesion to a particular group of histology because of slow indolent nature of these lesions, or to any histology depending upon the number and depending upon the site?
So people have done that. It's not that people have not done that. See, we have come a full circle. We have been very, very selective. Initially, we have been extremely bold and remove whatever comes in the picture. I was never in that era. But later on, we started being very selective. And then we decide the resection strategy based on histology, site, number of lesions, etc. So you would remember in 1999, there was a Fong paper in liver metastatic in which there was the prognostic factors were there. Yuman Fong had put the prognostic factors. There it was one lesion versus more than one lesion in the liver. So we have been that selective. And later on, now what is there in liver metastatic, whether or not all the liver lesions can be resected or ablated safely. That's the only question we ask.
And any criteria, sir, in your institution for deciding the clinical risk factor to going for a straightforward upfront surgery, or do you want to give a neoadjuvant some treatment followed by surgery?
In which cases? In liver, lung?
All cases of oligometastatic disease in liver, lung.
Generally, we will be inclined to give chemotherapy before we operate. Generally, we'll be inclined to give chemotherapy before we operate. However, if the patient's symptoms are quite significant because of the primary disease, we would resect the primary there. I am a very staunch supporter of liver first approach. If it is a liver metastasis and the lesions are limited, then you actually remove the liver lesion and then go ahead with whatever treatment you want to give, especially in rectal cancers. Because in rectal cancers, it's a complex treatment. You have chemotherapy, radiotherapy, surgery, etc. So you get rid of the liver and then go to the rectal surgery, rectal cancer treatment, considering that there was no liver metastasis. So all these approaches are possible, but generally would be inclined towards giving chemotherapy before we operate.
When the risk factors are very high, suppose the size of primary lesion is very large, or
yes, we will give chemotherapy.
Number of nodal disease is very high at the time of diagnosis, or suppose the CE level is very high. When the unfavorable risk factor is there, then we give chemotherapy followed by the surgery.
Even if there are very limited risk factors, this patient requires chemotherapy. And majority of the times we'll go for chemotherapy before we operate. It is only in selected situations where we go for upfront surgeries. Those selected situations are symptomatic primary, whether it's obstructed bleeding, or if there are limited liver lesions, in that case, you can actually take care of the liver lesions first and then go for the rest of the therapy later.
So, Durgatosh, there are actually two randomized control trials addressing these issues, and one looked into perioperative chemotherapy and one looked into adjuvant chemotherapy. The perioperative chemotherapy trial is a little older, around 10 years ago, and the adjuvant one has come recently. And both obviously is talking about clearly resectable liver metastasis. Both of them showed there was increase in the progression-free survival, but when later analysis came, long-term data came, and when we looked at the OS, it actually didn't result in any survival advantage. So, I mean, in clearly resectable metastasis, we can say the last word has not been spoken yet. We also generally prefer to give chemotherapy, but data doesn't support very much that.
I agree with your concept, And the chemotherapy we give because of several reasons. And however, if I open up a case of a right colon lesion and I find a liver lesion sitting there, I would not wait. I would just resect both of them and then give chemotherapy later. That's fine. What I'm trying to say is, if there is a rectal cancer requiring preoperative chemoradiation and you have a liver metastasis, what do you do then? I'm not going to operate the rectal cancer, which will require a chemoradiation before surgery, just because I have to do a upfront surgery. No, I will either give the patient chemotherapy and then look at which lesion needs to be resected earlier, or I will resect the liver lesion and then consider the rectal cancer separately, and then give chemoradiation to the rectal cancer and then do surgery for rectal cancer if it is not that symptomatic. So that these complex decisions are mainly for rectal rather than the colonic lesions.
I think it was a very good summary of metastatic disease, where possibilities and what we can achieve by doing aggressive surgeries. With this, Asit,
Yeah,
Thank you.
yeah, I think you can take over. And thank you very much, sir. Thank you for being there.
Thank you so much. Thanks.
is my slide visible?
Yes, Asit.
It is, right? Okay, yeah, good evening. I mean, that was a very engaging discussion, and thank you, Dr. Durgatosh, for setting the tone. I believe my task is actually cut out. We have had a baseline, and what I'll be doing is that I will do some real world cases, and as we move along these cases, we will discuss about how to manage them based on the guidelines which has already been discussed. Though I do not actually believe in some of the facts that has been stated earlier, especially regarding peritoneal disease and the para-aortic nodes, but yes, everybody is open. I mean, these things are open to discussion, and everybody is open to have their own thought processes. So before we start, I would like to welcome our panelists. I have Dr. Vinay Kumar with us. Hi, Vinay. Welcome to the panel. We have our dear old friend, Abhishek. Hi, Abhishek. Good to see you. Yeah, hi. We have Dr. Sapna with us. Dr. Sapna, good evening. I hope you have joined us.
Good evening, sir. Yeah.
Hi, how are you?
I'm
And
good.
we have Dr. Sunny Garg.
Hi, sir.
Uh,
Good evening.
Hi, Sunny. We are shamelessly surgeon heavy, but that's how we are. Surgeons need to hunt in bunches because the real sharks are out there, medical oncologist and radiation oncologist. Right. Okay. So this is the panel. I think we are minus Dr. Durgatosh, so that's okay. So this is a case. I will be discussing with only 3 case scenarios here. One is colorectal cancer with peritoneal metastasis. Second would be with lung metastasis, and third would be from the para-aortic node metastasis, right? So this was a 70-year-old gentleman, ECOG status 0, no comorbidities, no addictions. He presented with anemia and bleeding per rectum. Colonoscopy showed a growth in ascending colon, and a CT scan showed peritoneal metastasis. The biopsy from colon is moderately differentiated adenocarcinoma with mucin. Now, this is a moderately differentiated tumor, and presentation is with peritoneal disease. So this is the picture of the initial CT scan and the PET scan, which shows disease surrounding the omentum, the right side of the peritoneum, and obviously the subhepatic spaces, which is not visualized very clearly here. So let me start with Dr. Vinay here. So Dr. Vinay, when you see such a scan, what is your impression? Do you treat this patient as a patient who has a potential of cure in future, or you will disregard such a patient for any curative treatment options?
You have done a PET CT, and there is a metastatic lesion in liver along with the primary of colorectal
No,
cancer?
there's no lesion in liver. It is in the peritoneum. This disease has only spread to peritoneum.
Peritoneum. So you have to investigate the brain also, and you have to do the complete metastatic workup.
It has been done. This is the only site of metastasis. So it is a primary right-sided colonic tumor, which is non-obstructing with peritoneal metastasis. PCI, I will discuss about PCI. I think we had this discussion in in the talk, as well as how to have a clinical or radiological PCI and how accurate it is. So if this is the picture, what is your take to begin with?
So we start differentiating the patient into two groups, whether it is depending upon the clinical risk factor of the patient. Suppose it is CE. Can you tell me the CE value?
CE value is around 15.
So if there is more than one tumor, CEA value is very high, and there are nodes, perinodal disease, size is more than 5 centimeter, and then we can take it as a patient of a poor favorable outcome, and the clinical risk score we take as a 3 to 5, and we go upfront for the chemotherapy. And suppose we will also do the metastatic workup for the patient along with these markers, the KRAS, NRAS, and BRAF. To plan our immunotherapy also, which is the first line given in this metastatic setting. And if the favorable outcome is comes under the score of more than 3, then we start suppose FOLFOX or FOLFIRI plus bevacizumab or cetuximab this targeted chemotherapy for 3 to 4 cycles, followed by evaluation for the response of the chemotherapy. And then we will plan out, if the response is good, then we will plan for the gross cytoreductive surgery along with the radical colectomy. This will be our plan of treatment.
Right. So, Dr. Abhishek, I mean, for a colorectal peritoneal metastasis, what is your cutoff for a patient for whom you would consider for a potential curative surgery in the form of cytoreductive surgery and HIPEC? So I heard the discussion that was going around the PRODIGE 7 trial and rest of the things. So a lot of people talk about PRODIGE 7 in a negative connotation. Actually, it's not a negative trial.
Yeah.
What PRODIGE has made us is, it has made us much wiser, as we know which subset of these patients are likely to benefit from a cytoreductive surgery. Now we know that a patient who has a PCI of probably more than 16, we do not offer any advantage by giving them CRS and HIPEC. A patient who has a PCI of less than 10 probably does not benefit from adding HIPEC to cytoreductive surgery alone. So the patient subgroup of a PCI between 10 to 16 is actually a patient subgroup which benefit from a cytoreductive surgery and HIPEC. So is this the principles that you follow, or you had some other practice guidelines in your setup?
So prior to PRODIGE 7 came into picture, the PCI was very arbitrary, I would say. And somebody would go with PCI of 12, as Dr. Durgatosh alluded to. And we were, because I was at AIIMS at that time, we were, to start with, we were very aggressive with PCI, but then we realized that many of the patients relapse very soon if you have higher PCIs. Now, as you rightly alluded to, the PRODIGE 7 has actually brought into, has highlighted a few points. The number one, that the HIPEC might have a role in the subgroup of 10 to 15, though we don't know what drug to give in this HIPEC group, in this patients who are subjected to HIPEC. Secondly, HIPEC with oxaliplatin does not work because most of these tumors are CMS4 type. So the molecular subtype is of aggressive type, and oxaliplatin doesn't work in CMS4 type tumors. And so, as you rightly said, so the PCI cutoff that I would follow is around 20, based on the consensus statement by the French group. The same group who were involved in the PRODIGE 6 have come up with a consensus statement of around 20. They have not mentioned the logic for that. But as you rightly said, in the PRODIGE 7, 16 would ideally be the better cutoff. And the other thing that I would say that whenever you are assessing these patients, you have to look at the small points, as you mentioned, for the younger students, anemia, the presence of symptoms in these patients, what is their age, what is the CA level, what is the histology. Those are very important markers to decide the treatment in these patients.
Right. And there was another point that was being discussed. Somebody asked about the histology. I think it was Shefali asked about it. So actually, there is some data to suggest that when you do cytoreductive surgeries and HIPEC for poorly differentiated tumor like Cygnus Pringsets pathology or a poorly differentiated tumor, these patients do not fare as well as others do. So it's not an absolute contraindication, but the amount of advantage that you probably derive out of these patients would be much lesser as compared to anybody else.
So you need to tell the patient of Signet histology that your disease is more likely to recur than patient with non-Signet. That is clearly to be told to these patients, irrespective of the PCI. So these patients rarely have good outcomes as compared to the non-Signet ones. That has to be clearly told to the patients and their relatives, right?
So, Sunny, if I may ask your inputs. So, if you have such a patient, would you want your surgeon colleagues to go ahead with surgery upfront, or you would probably argue with them or try to convince them that giving chemotherapy upfront prior to surgery is always better in such a scenario? What is your take on this?
Definitely, in such kind of a case, I will always prefer to go ahead with some kind of a systemic therapy, because it also tells us about the disease biology. Because the response to the chemotherapy, it's a surrogate marker of how well the patient might do in future. And it gives us some more time that if the patient is not even responding to the systemic therapy, it's very highly likely that even after surgery, the disease has a high chance of coming back. So even if it is an oligometastatic disease with very few mets, like we were discussing for liver and all. So many times in tumor boards, we go ahead with some kind of systemic therapy to know the disease biology. And
so I would probably not agree to the statement that all oligometastatic. See, in case of peritoneal disease, the concept of oligometastatic probably does not exist. So in peritoneal disease, we cannot count the number of deposits. So we are taking it as a solitary site. So in peritoneal metastasis, I think this is one of the learnings that we have learned from PRODIGE 7, that upfront surgery. So in PRODIGE 7, the greatest 3 or 4 learning points that probably everybody has derived from is that one, HIPEC should not be done for 45 minutes. It's probably done for 90 minutes, which was one of the greatest drawback of that study. Secondly, like Dr. Abhishek said, that oxaliplatin does not work. So mitomycin C is probably the drug of choice, which is the drug now used in our setup. Third is no upfront cytoreductive surgery in HIPEC. Even if the PCI is very little, we will always give chemotherapy first and then go for cytoreductive surgeries and HIPEC. And fourth is the amount of PCI that is acceptable to various people. So like you said, people were aggressive going beyond 20, 24, 25, but now people have become wiser and they have started restricting themselves. And most of the centers, including ours, consider 16 as a cutoff for an invasive adenocarcinoma of colon or rectal origin.
So there's one point. There is a trial which has been done on this perioperative chemotherapy in patients with CRS and HIPEC in colorectal mets. And there's still acquiring patients, but this pilot study, Cairo 6, shows that the response rates are not very good with radiological as well as pathological response rates are only to the tune of 1/3. So I hope we should have better agents in future which can improve the response rates. That's the only thing. And this trial will tell us more about the benefit of this perioperative chemotherapy in the setting of CRS and HIPEC.
Sure, it does.
Yeah, so Dr. Asit, one question if you permit. So, I mean, like you rightly told that now, I mean, we are heading towards some kind of neoadjuvant kind of chemotherapy followed by CRS and HIPEC. So there are 2 questions. Would you go for a staging lab kind of thing to assess the PCI upfront and then go for chemotherapy? Because as it's been discussed that radiology is not the right way to assess PCI. And second important thing is, should we add on biologicals? What is your take on it? Because otherwise, in a potentially resectable liver, we do not, routinely add biologicals unless until the conversion is the aim. So what is your idea on that in case of peritoneal mets?
So Dr. Shefali, the clinical PCI that we have on basis of either a CT scan or MRI, now there are actually specific peritoneal sequences for MRI developed now, in which it is specially designed to look out for the mucin and the mucinous component and its invasion on the peritoneum. So the specialized centers have started doing it. So the concordance of the radiological PCI to actual PCI when we go, it's now as good as about 90% and above, right? So in case of colonic tumors, we usually do not do the diagnostic scopies or staging scopies prior to this. But yes, if it is allowed, or if you are going inside with a curative intent and it was unknown and you have found it out, yes. But in a case of known colorectal peritoneal metastasis, in which we have planned a chemotherapy followed by a cytoreductive surgery, as if now we are not doing any staging scopies. For stomach, we definitely do, as you know, but for colon, we don't.
So I think that is more of a reason that we are moving towards neoadjuvant kind of chemo, because true assessment of PCI in not otherwise mucinous may not be a true picture on radiology. And to add on biologicals, what is your take on that?
So we have used
or
it in,
any panelist can take that.
Yeah, so I think let us have Sunny to answer this question. Sunny, what is your take on adding biologicals to these patients? So my concern as a surgeon would be, if you add biologicals, say you're using BEV, I would be very skeptical to operate this patient for at least 8 weeks, because cytoreductive surgeries are very morbid procedures anyways, and BEV can lead to severe complications, especially wound healing and anastomotic breakdowns. So I would need a minimum of 8 weeks BEV-free period before I go in. So Sunny, you can share your viewpoint on this.
You're absolutely right. With regarding BEV, 6 to 8 weeks is the minimum time period required, as compared to 4 weeks with other kind of systemic therapies and then biologicals. So as rightly pointed out by Dr. Shefali also, that in the case of liver metastasis, if we are not eyeing on the conversion, then we can do away with biologicals. But I think with peritoneal metastasis, we do not have any particular data regarding omitting biologicals or not as such. No particular trials on this in this particular case scenario. So I think we should go ahead with the biological thing and get the this NGS panel done, pan-RAS testing according to that, and MSI MMR testing done. According to that, we should take the call whether to do upfront biological plus chemo or immuno, and proceed with the standard protocol of the metastatic treatment. And obviously, after if we are giving bevacizumab, then we have to give a gap of 8 weeks. So that we have to discuss with the surgeon and take the call accordingly. But no particular, I think there is no particular specific change in the metastatic treatment in this particular case scenario.
So this patient did receive BEV. Actually, Shefali, you only gave this patient, this gentleman, anterior chemotherapy. He got FOLFOX plus BEV into 6 cycles. And when we had a window of about 8 weeks in between, so he was given one BEV-free FOLFOX. There was, on the reassessment, there was good metabolic and anatomical response. As you can see in this, there was not only the metabolic response where it became FDG non-avid, there was anatomical regression of the disease as well. Now, in such a scenario, are you open for cytoreductive surgery and HIPEC in this patient? Dr. Vinay, would you be happy to offer CRS and HIPEC in this patient or not? Dr. Vinay, can you hear me? Are you there with us?
Yeah. So how many cycle of bevacizumab and Folfox?
He's had Folfox with Bev 6 cycles and one Bev free Folfox in the interim when we were waiting for 8 weeks, and he had a good response, both anatomical and metabolic.
So the response appeared to be into what any criteria, RECIST criteria of response evaluation was done in this patient.
Yes, it was. So he had more than 30% reduction in the size as well as metabolic response.
Metabolic response, what was the criteria? Means RECIST criteria. It is complete response or partial response. Or this disease does not appear to be static here. So I think there is a partial response or complete response. What was the RECIST criteria of evaluation in this patient?
Has more than 30% reduction in the size as well as the metabolic activity.
Then there is a definitive role of this radical surgeries when the response is very good, and we should go for CRS, and then there's a HIPEC 90-minute mitomycin. What we have the guideline from the coming trials, we should straightforward go for the strong cytoreduction, and that will benefit the patient a lot.
Right. So Abhishek, would you agree? Would you be happy to go ahead with surgery in this patient?
So what is the PCI as per the radiologist?
So PCI is close to 10 in this case.
Yeah,
It's the right upper quadrant disease and disease in the subphrenic region on the right side.
CA has shown a downward trend.
Yeah, CA has normalized after chemotherapy.
I think though he's 17, he has no comorbidities, he is in good health, ECOG 0, as you said, even after chemo, if he's maintaining his physical, is in good condition. As you said, we'll wait for some time and probably subject him to a CRS. HIPEC is as per the institutional protocol. Depending on if you want to use HIPEC, use it with mitomycin C.
Right. So this is what happened. This is the disease on the peritoneal surfaces, as you can see, and this was the disease on the right side of the diaphragm, along with the tumor in the hepatic flexure of the colon, and this is the post-operative picture, and these are the post-peritonectomy picture. So this patient did undergo cytoreductive surgery along with HIPEC. So Sunny, if I can ask you, what is your protocol? What drug do you prefer in colorectal cancers for HIPEC? Is it mitomycin C? And what is your take on using the doublet drugs for HIPEC? So do you have any experience, or are you aware of any such data which talk about addition of any other molecule to mitomycin?
So not much of experience. So in most of the cases where I have assisted in the HIPEC, so mostly used mitomycin C only. No experience with the doublet therapy.
Right. So what we use, Shefali, are you aware of any such data now? There's a lot of actually data emerging for
for doxorubicin. Use of doxorubicin is there. Oxaliplatin, as you rightly said, was initially tried, but I mean no good results with that. So there are multiple regimens. People have tried using doxo plus mitomycin also, and doxo in the dose of 15 milligram per meter square along with mitomycin. So what we generally use as an institutional protocol also, and as a standard also, that we give mitomycin C as a flat 40 milligram dose. Though the range in various trials varies from 15 to 30 milligram per meter square. We use mitomycin C.
And we are using it for 90 minutes.
Yeah, absolutely.
Sunny, how long do you use? Do you use for 90? Do you use it for lesser duration?
90 minutes and flat 40 also.
Flat 40. So Abhishek, what is your protocol at your center? Are you using HIPEC for 90 or you're using it for
90? The patient is tolerating. Most of the time you have to be around the patient, monitoring the patient. You have to be very, in 70-year-old, I'll be little,
that our anesthetist will do. We will go chill out for 90 minutes.
So if the patient is not on, is hemotably stable, obviously 90 minutes would be better.
Right. So this is our institutional protocol, and this is what we would be doing. So I think for the colorectal peritoneal metastasis, I think the present scenario where we stand as if now is that it is definitely something which we can offer with curative intent. We have to be a little conservative with our approach. The disease biology should be selected out with the use of neoadjuvant chemotherapy. And aggressive disease, poor histology should be avoided if possible. And mitomycin C is the drug of choice. Duration of HIPEG is 90 minutes, and the temperature that is ideally should be achieved is 43 degrees. And this is what we are following, and this is what has been proposed by most of the guidelines. So let's move on to the next topic, that is colorectal cancer and lung mets. I think we haven't used the expertise of our radiation oncologists thus far, and I'm very sorry, Dr. Sapna, there was no opportunity for us to involve you in peritoneal disease. So we will we'll make comments in lung mets, and we'll let you irradiate as much of lung as possible.
No, it's okay, sir. But I just wanted to make one comment that maybe in future MRI-based SBRT is coming for solitary peritoneal mets. So maybe look forward for SBRT in future.
Oh, wow. Amazing. This is one something to look forward for. Exactly. So again, another patient with colorectal lung metastasis, 54-year-old gentleman, ECOG 0, presented with easy fatigability and anemia. Colonoscopy showed a lesion in hepatic flexure, and we usually initial staging is at our center is with CT thorax and abdomen. And when we did that, we found a lesion at the hepatic flexure and a solitary lung met. The biopsy from a moderately differentiated adenocarcinoma, and this is the radiological picture, as you can see here. So we have a lesion right at the hepatic flexure. It's a bulky disease, but patient is not in obstruction. As you can see, the small bowel is completely collapsed, and there is a lesion in the right lobe of the lung. So let me start with our surgical colleagues. Dr. Vinay, what is your take in this patient? How are you planning to propose how to treat this patient? Are you open to a concept of, since it's a very special variety of an oligometastasis, it is actually a solitary lung mat. So if you look at the literature, they behave very differently from people who have more than one met. So multiple mets. Even though they qualify as solitary, but they qualify at oligo, but that's a different class. So are you open to upfront resection in these patients, doing a colectomy along with metastatectomy from the lung?
Obvious for the reason, because the patient you are presenting is an obstructive lesion.
No, it's not an obstructive lesion. Patient is non-obstructive.
Non-obstructive lesion still, and this is solitary metastasis in lung there. So then you have to do again, have you done the PET CT in this one and the MRI brain to work up for the whole body metastasis?
So we don't do MRI brain for any of our patients in colorectal metastasis as long as our PET scans are normal. As a protocol, we don't do it. MRI brains are a routine protocol only for lung cancers, not for any other cancer in our setup. We do PET scans if it is clinically indicated, not as a routine protocol. So since this patient had a good quality abdomen CT and a thoracic CT, a PET was not done for this patient.
I do suggest, and we at our center at AIIMS Bhopal, we do the brain MRI screening, because to confirm the subtle metastatic which we may be missing in case we are planning our resection. So always we combine our PET scan with MRI brain when we have such type of settings in lung metastatic lesion along with your colorectal part.
I mean, is this your institutional protocol? Because I think, I mean, this is a little odd. I mean, I've never come across any such guidelines. Correct me if I'm wrong. But so the lung metastasis in colorectal cancers in absence of, having a normal PET scan, it is something which is very unheard of. So, I mean, what is the basis of this practice that you're following?
The basis of this institutional practice is that the disease is stage 4, or in any stage 4 metastatic disease, we have to work out the whole body to pick up the subtle metastasis which may be missing because there is no clinical symptoms.
Okay, so presuming that his lung met, brain MRI is normal and a PET scan does not show any other lesion anywhere else in the body. So these are the only two sites of disease. So what would be your approach?
Again, our approach in such setting is, if we have a diagnosis of histopathology, then we will do all panels for the molecular panels to confirm what nature of the disease is there. We have to do the markers, that is KRAS, what is the KRAS, what is the NRAS, what is the BRAF. Your MSI panel you have to work out. All molecular markers in a metastatic setup you have to do before planning your therapy. So can I confirm those have been done here?
I must tell you, Dr. Vinay, your medical oncology colleagues are very accommodative. If I talk about these molecular markers,
Yeah, Dr.
Shefali,
Asit, I was
she will
going
kill
to
me.
interrupt you here.
She
I
will
was
kill
going to
me.
interrupt you here.
So I
right
dare
now.
not. I dare not speak all these words in
You
front of
investigate the patient depending upon the stage. You are giving me and telling me your patient in a stage 4, then as an
No, Dr.
oncologist.
Dr. Vinay, sorry to interrupt. So Dr. Vinay, Dr. Asit and Dr. Abhishek, would you not like to biopsy this solitary lung lesion? I mean, what is the reason you would not like to biopsy this solitary lung lesion before proceeding for metastasectomy?
No, suppose you are telling me a lung lesion and it is picked up on PET CT also, and uptake is of adenocarcinoma, then I don't need it. The biopsy is needed because it takes the procedural cost, it takes the time. And it is upfront disease on PET CT when histopathology.
No, couple of times it is a second primary. It's a TTF1 positive solitary pulmonary nodule lung primary. So we have couple of cases now. What is the harm proving it?
No, if the uptake of PET CT there in colon and PET CT would give you exactly how much the uptake lung is picking up and how much uptake is colon is picking up. And if both the uptake are similar, then you can confirm it is colon primary if the uptake are similar in both the region. So don't need to do the biopsy to confirm this region is lung or lung primary or colon primary.
So I would
little disagree.
in such a scenario, I'll discuss with my radiologist. And this slightest
people, any nuclear medicine people can confirm what I am telling. Can we pick the primary lesion depending upon the value of uptake, because the histology nature and the uptake both corroborate during the radiology uptake and take up of the lesion. So no need to biopsy if the metastatic uptake are similar in both the places.
So
I
I
will
think,
like to
I
go
would
with,
agree with what Vinay is saying. If your radiological pictures, your CEA values, your rest of the imaging characteristics are suggestive of a metastatic disease, and if you are planning a treatment solely on the base of, say, if I were to resect this, I don't think I need to prove it mandatorily. If your other things are off, if your radiological picture is a little different, if your FDG avidity is slightly wavered, which is not commensurating well with your primary, and if there is any odd point, I would definitely want to biopsy it. But everything is
there are 2-3 points. So there are 2-3 points. If your colon primary has a metastatic lymph nodal disease, heavy nodal disease in the abdomen, plus there are large mediastinal lymph nodes and a solitary lung nodule, I still think that only, I mean, you can get away with that thing. But if this is a solitary lung nodule, no mediastinal lymph node, no heavy abdominal disease, it is worth doing a biopsy in this patient. We have had couple of such instances, not single anecdote, but couple of those instances.
See, Dr. Shefali, we might have had couple of instances, but still majority of them are metastatic deposits. Colorectal liver metastasis will usually not spread to mediastinal nodes. I agree that they might spread to the regional lymph nodes in the abdomen. In their absence, you might be a little suspicious that it could be a second primary. But as a rule of thumb, if you want to biopsy every such lesion, I don't think that will be acceptable to most people. However, if you are trying to deal with some other treatment modality, say if you were to radiate this. So let's ask Dr. Sapna's opinion. So Dr. Sapna, if you were to radiate this lesion, would you necessarily require a histological proof from here, or you are happy if you have a histological proof from colon saying that it's a adenocarcinoma and this lesion could be a secondary?
And that it appears to be a very controversial question right now. But I think depending upon the histopathology of colon, I would like to go just like that with the SUV uptakes. If they are similar, I would like to take it as meds only.
And you're happy to irradiate this, right?
Yeah.
Right. So I think, Shefali, your point is well taken, that if there is anything odd in the either clinical picture or radiological picture, then we should not take it, on its face value, it's always prudent to prove it if there is any odd point, rather than, burning our hands later on. So having said that, so this patient was worked up. He also had a PET scan which did not show any other lesion. The uptake in colon and the lung was commensurating very well. And this patient now, so what are the management options here? So we have a colorectal cancer. You have colorectal cancer with a single lung met. So do you want to start this treatment with chemotherapy with plus targeted therapy? You want to go for surgery upfront with chemotherapy? You want to give anterior chemotherapy followed by surgery? So what are the various treatment options? I mean, we will talk about radiation as a curative modality in lung as to how many lesions which can be radiated when surgery is not an option. So I'm primarily a GI surgeon, so I don't operate on lung cancers or lung pathology. So I will want Vinay to chip in there, and obviously Sapna to guide us on those two guidelines. So Sunny, what is your take? Do you want your surgeons to take this case as or you would want this to be treated with curative intent, or single lung met is something that, or a multiple lung met is something which is off chart for curative intent?
So I will, in this particular case, there are some negative, some poor prognostic features. Like first is synchronicity. The lung mets has presented at the same time as the primary. And second thing is there is no liver disease. Without that, there is distant involvement of the lung. So these are the two features. And I will like to know the CEA level also. And
CEA was 25. Did I not mention it was 25?
So CEA is also elevated. So these are the three red flags which might indicate disease biology on the poor side. And so I will like to go ahead with a systemic therapy first and see the response to that, and then go ahead with the any curative intent, whether it is surgery or radiotherapy, because of these three particular things.
And would you like to add any targeted therapy to this, or you are happy giving the standard FOLFOX in this scenario? We don't want any downgradation. We don't want any conversion.
No, we should give the benefit of target, although there is no clear-cut doubt about the conversion in this particular case, and it is upfront acceptable. So, but despite that, I think we should go ahead with the targeted therapy as well as chemotherapy both.
So, contrary to the fact that it has been almost there is a plethora of data that says that if you are not aiming for conversion or downstaging, there is no additional role of adding targeted therapy to anterior regimens. I mean, why do you say that you would give benefit of doubt? I mean, what benefit we are, or what doubt are we trying to clear up here?
These 2-3 particular points which I have already stated, if it would have been a metachronous kind of a thing, okay, after a gap of few months or 1 or 2 years, this lung single site would have appeared, then and the CEA would have been lesser or normal, or there would have been previous liver mets, and then there was a lung met. So then we could have gone ahead with chemotherapy alone. But because of these 2-3 particular things, I would like to give the benefit to the patient of targeted therapy.
Fair enough. I think data may not support this approach, but I think, I mean, you are fair in adding.
So I would like to add one thing. Of all the mets, the non-regional lymph node mets, liver, the lung is probably the best site, prognostic-wise. So if you have a patient who has a liver and a lung synchronously, I would decide the management as per the liver, not as per the lung. The lung is the best of all the prognostic, if you see the data. And as you were rightly, I got your point, what you're trying to say, whether you go with upfront surgery in such kind of patients. There is some data to support the use of upfront surgery, maybe staged or for these tumors. But generally speaking, neoadjuvant would be the perioperative would be the way to go.
So if you talk about this specific subset in which it's not oligometastatic, it is solitary metastasis, which is given a different subset as compared to oligo. If you see the data for solitary mets, especially lung or liver, upfront surgery without any anterior chemotherapy is a it's an acceptable, rather, I should not be
So
using the word preferred.
But number, I think you should look at the CA value, you should look at the histology, you should look at all those things. So if everything is favorable, maybe very super selective patients with solitary lung mets who are, have good biology as per the clinical parameters could be suitable for such approach, though evidence is still lacking, I would say. That's the way. But you could.
Dr. Asit, yeah, in this case, I would give you that advantage of doing the surgery upfront. I would not much argue for giving perioperative, because like you rightly said, that solitary pulmonary nodule is something which is an entirely different subset. So I think both approaches hold good. There is no data for or against either of them strongly. So that is the thing.
So Dr. Vinay, what is your cutoff point for offering resections?
I think Dr. Vinay has left.
Dr. Vinay has left.
Okay. So let us ask Dr. Sapna about this. Dr. Sapna, what is the radiological paradigm here? How do you treat the metastatic lung lesions with the curative intent or the radical intent? So what are the cutoffs and what are the various paradigms, if you can educate us a bit?
So I think this case is an ideal situation where SBRT would give us a lot of benefit as compared to surgery, resection of the solitary lung mets. And basically, we include patients who have worse baseline factors, which are not surgically operable, which have older age group and maybe shorter meds-free interval. These type of patients can also be included in our setup with the SBRT. And there is some reason that these kind of metastatic nodules, which are because of CRC, they are slightly more resistant as compared to the other lung mets. First of all, there are satellite tumor cells. And second is that there is higher ratio of hypoxic cells. So the studies, hello?
I think there is some disturbance somewhere. I mean, you can continue, Dr. Sapna. That's fine.
Okay. So with pulmonary metastatectomy with negative margin also, there is recurrence rate of 19 to 28%. But with SBRT, there is a lot of high degree of safety, and we can give almost dose as high as 60 gray per fraction. That is a very high dose, and ablate the tumor, which is this size, which has been seen in the photo, and can achieve a very good response. That is 67, almost 60 to 90, almost 100% response can be there.
So how do you manage if you have lesions at different locations or maybe in both the lungs? So is there a cutoff, and how do you allocate the doses differently? So just pardon us. I mean, we are very naive to all this. So we're trying to extract as much information from you as possible.
Perfectly fine, sir. Sorry for my voice. Actually, my throat is not well.
Yeah, absolutely clear. Don't worry.
Yeah, it's the criteria which is there generally is that we usually see for 3 to 5 pulmonary nodules. The cutoff is 3 to 5 pulmonary nodules. The dose planning will be done at the different places where the lesions are existing, and the dose which we give to each lesion is actually a consensus of many studies. Usually it is between 60 gray in 5 fractions, sometimes 48 gray in 4 fractions. That is, I'm just saying about depending upon the size of the tumor. Because for peripheral lesions, like in this picture, we can see up to 2 centimeter, we can treat with 60 grays in 3 fractions. Which are the lesions towards the center, 2 to 3 centimeter, we increase the dose, 48 and 48 grays in 4 fractions. And the central lesions are the most difficult to treat because they are near the hilum and near the lymph nodes also. Most likely they might have involved the nodes, and the doses are usually more than 60 grays in 8 fractions, 8 to 10 fractions. So that's a very high dose, and a lot of high precision planning is needed, and sharp follow-up and all those. I mean, the techniques are a little bit difficult to follow, and we have to stick to the rules and guidelines while giving to solitary lung mets especially.
Is there any cutoff beyond which you'll say, okay, this is a no zone for me, we can't radiate this, as per the size or as per the location or for multifocality or number?
Yeah, number, I already said that it is usually 3 to 5 which we take.
Okay.
almost till 5. Sizes till 3 centimeter we can take. That is there. And one more thing which you asked was
the location.
Location is no as such not a question for us, because we can treat either if it is peripheral or central or maybe in the middle. So all 3 sites can be treated because it is easily accessible on radiotherapy, even if it is not on the CTVS.
Okay. Thank you. So like Shefali said, that our medical oncologists are very accommodative with us. So we decided to go ahead and resect this lesion. Patient underwent laparoscopic right hemicolectomy, a radical D2, and pulmonary metastatectomy upfront. And then he received 6 months of pseudoadjuvant FOLFOX without any targeted therapy. Obviously, there was no target left for Shefali to act upon. So, so the point I'm trying to make is that obviously, like everybody said, that so you have to individualize the treatment to your patients. But the notion that a metastatic disease has to be treated with chemotherapy upfront and surgery upfront has no role is probably not the right notion. You can, in selected patients, in good risk patients, in patients in you feel that the radical surgery can be done and a good biology disease, surgery upfront in even a metastatic disease like lung and also liver is feasible in certain case scenarios. So the last scenario we're going to discuss today is paraaortic lymph node metastasis. So again, a 60-year-old man who had a history of carcinoma sigmoid colon. He had anterior resection and adjuvant chemotherapy. The biopsy of the surgery was P3N1M0. He was on regular follow-up, and after about 1.5 years of regular screening, he showed a rising CEA trend, and a PET scan was done, which showed these lesions in the paraortic node. So if you can see the lesions on the right, they're adjacent to the large paraortic node, and there is a node along in the territory of IMV as well. So what is your take in this case? I think Vinay has already left us. So Abhishek, you are the only surgeon left who can argue for surgery. So
yeah, if I can read this CT scan carefully, is there a lymph node chain, a long lymph node along the right of the aorta? Is that correct?
No, to the left.
Okay, okay, that is something that is standing
on the image above. On
so
the right
there are
image,
2 nodes, left paraortic nodes. There is a single site. Only isolated paraortic node?
Isolated paraortic lymph node recurrence after about 1.5 years of primary surgery and receiving 6 months of FOLFOX.
Right. So the data, there's no control data to compare chemo alone versus surgery in these set of patients, but the retrospective data suggests that the survival is of the tune to the equal to liver mets if you do a proper RPLND and if the location is below the left renal vein. So I would is a 64-8-year-old male who has come after interval of within 2 years, which is not a good thing.
2 years, so it's 1.5 years after.
DFI of more than 2 years is more favorable prognosis, but still, to give benefit of doubt, and I don't know whether we should give chemo first, then operate, but in this patient, I would like to give a second-line chemo maybe, and then he does not require conversion. I will not add. I will not discuss the option of targeted. Maybe a second line, and then if he is still okay after 2 months of second line, I would subject him to a RPLND with the help of my urology colleagues.
Okay, Sunny, what's your take on this? Would you like to give this patient second line chemotherapy? You want to add, since it's a recurrence, nodal recurrence. So this patient had a recurrence in the region of IMA node as well, and that another node in the paraortic region. So it's a chain. So how would you want to treat this patient as?
So this patient has recurred early very early. 6 months is a very short time.
No,
for
not 6 months, 1.5 months, 1.5 year, 1.5 year.
18 months.
1.5 year. Okay, but okay. So it is like a in for colon curative post curative resection and completion of adjuvant chemo. 1.5 month is not a very long time. We will consider it as a early to mid time recurrence only, and definitely in this particular case we will wish to know how the tumor behaves in future, and start with the systemic, not hurry on doing the surgery. And obviously we will this is 18 months. So although the cutoff is 12 months for changing the regimen, if we give Folfox, we have to change it to Folfiri, or changing it to different kind of a protocol. But yes, in 18 months also I will like to give the benefit to the patient of a different chemotherapy regimen along with the targeted therapy. So we'll like to go ahead with the NGS panel and MSI, and take the decision based on that. Also, the performance status of the patient I will take into account. Based on that, if we can also consider giving the triplet of Folfirinox, Folfox3, combining. No, sorry, not in this case. We have already given Folfox, so Folfiri with the targeted versus immunotherapy based on the NGS reports. But definitely we should consider giving systemic therapy followed by
So what is your intent here? Are you treating it with a palliative intent? Do you think curative resection is?
I think curative resection is very much possible. I'm not at all considering this to be treated with a palliative intent, but 18 months is not that big a time. 18 months is in between. Like, it is not a very early, also not very late relapse. So we should treat the patient aggressively with a systemic therapy and then go ahead with the curative intent. No doubt in that.
Right. So, Dr. Sapna, I mean, are you keen on radiating this patient? Do you think this location is suitable for radiation? There's just a couple of nodes lying to the left of aorta, one node in the mesentery close to IMV. So, do you think this is something which is manageable with a curative intent, radiation with a curative intent, radical intent?
So basically, SBRT is planned for such lesions only, which are not accessible by surgery properly, because para-aortic lymph node dissection is something which is very, it stays in the gray area. I mean, how much you're resecting out, about the margin status, and after chemotherapy, the morbidity is going to definitely increase with para-aortic lymph node dissection. So this area which we are seeing here is a very favorable site to be treated by SBRT. And this can be easily contoured with a margin. I mean, we can give a wide margin around it. And especially, I'm saying against surgery because there are many critical structures also around it. And in that case, radiotherapy is more beneficial as according to the other modalities.
Right. So actually, retroperitoneal lymph node dissection or a para-aortic lymph node dissection like this is almost a routine in many urological procedures and gynecological procedures, and we have to do it quite routinely for many other procedures as well. So the morbidity of this is, to be very honest, not much, and there's hardly any risk to the patient or anything of that sort. The second point that has to be taken in consideration is that how adequate the lymphadenectomy was done at the index surgery. So this is something I think I failed to elaborate this point. The initial surgery was not done at our center. It was done somewhere else. And when we reassessed the histopathology, the total lymph nodal yield was about 6 nodes in this patient. So our thought process was that probably there was an inadequate lymphadenectomy, and those lymph nodal chain has probably over the next 8 to 12 months have, from IMV node or IMA node, it has progressed to the para-aortic node, which is a normal continuation of those second, third echelon nodes. So, and like Shefali has already told us, that our medical oncologists have too much faith on their surgeons and they let us do all the hanky-panky stuff. So we actually took the liberty of taking up this patient for surgery. We actually operated this gentleman. This is the picture of para-aortic lymphadenectomy that was done. You can see the aorta and the IVC which was bared. This lymph nodal chain was actually it was in the continuation where the stump of the IMA was there from the previous surgery, and it was just continuing from there. So the complete para-aortic lymph node resection was done in this patient, and
This was the right colonic malignancy to start with.
left colon, sigmoid colon. Sigmoid
Yes. Okay. Yeah, that explains. Yeah. Okay.
Yeah, so that is why we actually were more aggressive in this patient.
Then it required surgery, resulting in might be.
So the message in this case is that even para-aortic lymph node metastasis is not something that should be, you should not discard a patient, that it's a something which cannot be cured. Para-aortic lymph node dissection has become a part of extended resections in left-sided colonic resections, along with pelvic lymph node dissections, and it's quite regularly done now. And like Dr. Sapna said, if patient is not fit for surgery, or if patient is not agreeable for surgery, I think radiating these field lymph nodal zones is something which is amenable with even a curative intent or a radical intent. I think with this, I think we'll bring our discussion to close, and I thank all the listeners and all the participants. I'm really grateful that you took out time from your busy schedules and spent past 1.5 hours with us. Back to Nikhil and Shefali.
Yeah, so there are a couple of questions. Should we take that? So Dr. Asit, Dr. Abhishek, any of you can take it, because more related to surgery, and Dr. Sunny to pitch in for the medical oncology part.
Yeah, sure.
So, okay. So somebody asked, so in rectal cancer with liver met, how to sequence chemo, RT and surgery. I think Dr. Nikhil has posted to see the past episode. So the next question, okay. If we have a colonic primary which was previously infiltrating other viscera, like duodenum, kidney or pancreas, and after NACT, the residual disease is free from the said structure. So do we go for a conservative surgery or a multivisceral resection? Dr. Raja asked this question.
So obviously the aim of one of the aims of chemotherapy is to convert it to downstage it to a more resectable situation. And it's a good thing that the viscera which was initially involved is now uninvolved, and one would not like to resect a viscera which is not involved after chemotherapy. So if, for example, the duodenum was initially involved, the second part, and it would have required a Whipple's to start with, and now the duodenum is free, I would not like to do Whipple's in such a patient. I would be happy doing a, right hemicolectomy. Yeah.
Yeah, exactly. So actually, that is the whole point of having a neoadjuvant or a downstaging chemotherapy.
One point to add here, Asit and Abhishek. So it generally doesn't happen that way. If something is involved, it will not become free.
Yeah, that's true. But the question was if it becomes free. It's rare to have that situation. You're right.
It will generally not have that. So if it becomes free, it means it was free. And in fact, we have data on this from liver metastasis also. Like if the vein or a biliary pedicle is abutted, and if you give chemotherapy, they just pull it along.
Yeah. So those kind of responses are rare. You're right.
Yeah.
Yeah, and the second question is, I think Dr. Sunny can take this. If patient is MSI high, so would you go for pembro upfront, or would you like to reserve it for later and use surgery wherever it is feasible even in the oligometastatic setting, and the surgeon's take also on that?
So if you ask me, there is no role of neoadjuvant immunotherapy in a curative intent setting. I would not prefer that. That is only reserved for situations where I'm not going for surgery, curative intent surgery, or curative intent treatment. That is a correct. Right.
I think Dr. Nikhil and Dr. Asit would be very happy to hear that.
Yeah.
So that
we are always happy. We are always happy.
All right. Okay. And I think then one I think last question is there.
So somebody asked us about that PET scan. I think Gagandeep is asking that there was an uptake on the right side. So that's not an uptake. That is actually the partial voluming of kidney that is showing off. So that's just kidney lighting up. And those nodes were positive actually. So, so the right sided, what you are saying is just the kidney. And what did he ask again? Extensive node met, usually bad behaving. So no, it's actually, so that was the whole point, that para-aortic lymph node positivity does not mean that it's a very bad prognostic feature, or it's something that you have to discard a patient, or it's a nihilistic approach. Para-aortic lymph nodes can still be treated like any other metastatic site, an oligometastatic site, and we should be aggressive with these patients, and we should be trying to achieve a radical resection and trying to do a RPLND like we did in this patient.
Right. And the last question was, is there any difference in adding targeted therapy in right versus left-sided? I think we discussed it in the last webisode where we extensively dealt with the chemotherapy part. So very well moderated, Dr. Asit, and very well conducted session. So we are coming to the planned last session, but we wish to continue for more. Be there any suggestions how to carry it on forward? So all suggestions are welcome. So Dr. Abhishek, Dr. Sunny, if you have any suggestions, or any of the audience has any suggestions, we would like to take it up.
Can I make a closing like on this, just regarding these two cases first, that I totally agree that yes, doing surgery upfront in both the cases was not completely wrong, but I still feel that in both the cases we should have given systemic first, because see both these cases, first case was there was a lung mets. Okay, there is a distant metastatic disease, and if we are feeling that giving neoadjuvant chemotherapy, the disease might progress. That is our fear, no, of doing surgery first. That giving systemic therapy, we are not doing the curative intent, giving the curative treatment first. And so if the patient progresses on the systemic therapy, then there is very highly likely that even after curative surgery, the chances of progression are very high. So let us wait and see the biology at least, because doing lung surgery, doing GI surgery is, for the patient, it is not a small thing. And similarly, in the second case, we could have waited and seen the disease biology, because I always believe, whatever the trials, no trial has come out with a clear-cut answer. But I believe that we should give some time and study the disease biology. And what is the hurry in doing the surgery? Like if the patient is responding, anytime we can go ahead and do surgery. But if the patient is progressing on chemo, then it is very highly likely that after surgery also he will progress. Okay.
So I can see Dr. Nikhil smiling.
This
is not argument, Dr. Sunny. I tell you, in our tumor boards, we are fighting like anything.
No, it is not a fight.
I tell you one thing. I tell you one thing where we come in concordance in our tumor board as a group or as a team is such kind of good biology diseases, the SPN and all, be it the multiple mets. So we generally do not argue. We just argue and then close the chapter by starting systemic in many of the cases. But solitary pulmonary nodule is something which is really a very gray zone. So we see how the patient profile is, how fit is the patient. Are we going to achieve a R0 completely? How difficult is the surgery? These kind of discussions go on. Dr. Nikhil may add on. Yeah.
Shefali, you have taken finally the surgeon side. I'm very happy. We have finally connected you.
Dr. Nikhil, I just want to make one comment to Dr. Asit.
Yes.
It's about para-aortic lymph node dissection. So very rightly, you have said that we are doing in each and every patient, and the risk of morbidity is very less. But the kind of patients we are getting sitting at our centers, they are not exactly fitting in the same scenario, because we are seeing para-aortic morbidity to a very larger ratio, and then the number of nodes are variable, which we are getting. That's why I was talking about the para-aortic lymph node radiation.
No, I totally agree, Dr. Sapna. I'm not saying that we do it for everybody. This was a very highly selected patient. So the cases that we have shown are actually selected out for what we have done. So I would have seen many other patients with many other lymphadenopathies in para-aortic region, and probably we would have ourselves discarded them out of surgical domain. So by no means I'm saying that you should be doing it left, right, and center with everybody.
Yeah.
But yeah, the notion that para-aortic lymphadenopathy is a very, very difficult or a very morbid procedure, or it cannot be done or should not be done, that's not there. It is very regularly performed. It's something which is now people are doing even laparoscopically, and we also do it. So laparoscopic para-aortic lymph node dissection and sampling, it's become almost a routine in most of the urological malignancies and any gynecological malignancies. So morbidity is hardly anything. We can definitely do it, but yes, whether you should be doing it in a particular case or not, that discussion should be done with the patient. And we're
in the tumor board also. I mean, we have every right to make
so
a comment.
tumor board में तो हमारे medical oncologists इतने sweet है, कुछ मना ही नहीं करते हैं, so that's okay.
Actually, I was just asking this question because I was just asking this question because I am more interested in gynae oncology, and therefore I just wanted to ask, up to what level do you take the para-aortic lymph node dissection?
Up to splenic, up to renal vein,
And how many lymph nodes usually you resect on an average basis?
So see, I do not do gynae oncology. I am just a GI oncosurgeon. But the number of nodes is not the criteria. What the gynae oncology, the template is that they do it right from bilateral renal hilum. You should be able to see the bilateral renal veins completely bare. You should see the ureters bilaterally completely bare, down to the pelvis, and to the bilateral iliacs. They make everything bare naked. And the way they do it, it's absolutely beautiful and fascinating.
Okay, thank you.
Yeah, and Dr. Sapna, I mean, in generally now in gynae oncology, we have started in very selected cases after tumor board discussion. If a single supraclav is there along with a small nodal burden of chain, we do radiate it. We treat like oligometastatic if it is really there. So in very selected patients, not a routine, but we do it in certain individualized cases.
Okay.
So yeah, thank you so much. Wonderful discussion, and good night to you all. I can see I'm in 9 o'clock.
Right.
Thank you.
Thank you everybody.
Good
Thank
night,
you so
everyone.
much. Really appreciate it.
Bye.